Dear audience, dear chair, let me introduce my PhD thesis topic, which is the importance of pancreatic exocrine insufficiency in pancreatic diseases. My name is Orsolya Eperjesi, and I am a third-year internal medicine resident at the Tor Reference Hospital and also a first-year PhD student. My vision is an early diagnosed and appropriately managed pancreatic exocrine insufficiency across pancreatic diseases, and to achieve this, my mission is the optimization of pancreatic enzyme replacement therapy in acute pancreatitis patients. For these goals, I have one ongoing project which aims to investigate the predictive risk factors of pancreatic exocrine insufficiency and the effects of pancreatic enzyme replacement therapy in acute pancreatitis patients. As the treatment and survival of patients with acute pancreatitis has improved dramatically over the decades, understanding the long-term complications is also essential. A recent meta-analysis by Huang et al. Demonstrated that the prevalence of PI during an index attack of AP can be as high as 60%. Although this frequency falls during the follow-up, persisting in a minority, and the PI prevalence is still about 30% after a 3-year recovery. So there is a high prevalence of PI in patients with acute pancreatitis, both during their initial hospitalization and in the long-term follow-up. As it is well known, PI can cause several intestinal symptoms such as abdominal pain, bloating, cramping, increased flatulence, tatorrhea, diarrhea, and weight loss, and all these pathological changes seriously affect the quality of life of patients with pancreatic exocrine insufficiency. Despite it, there are still many uncertain aspects regarding the treatment of patients with post-AP PI, and less is known about which patients need to be screened for PI after an episode of AP. So we asked the following questions. First, what are the rates of PI and the PI symptoms in acute pancreatitis? Here we use the COCOCO framework, and our hypothesis is the rate of PI symptoms is increased among patients with acute pancreatitis. Our next question is what are the predictive factors of PI in acute pancreatitis? Here we use the PFO framework, where the population are patients with diagnosed acute pancreatitis. Factors will be any risk factors that we can identify, for example, etiology, severity, necrosis ratio, localization of necrosis, and so on. And the outcomes will be pancreatic exocrine insufficiency. And our hypothesis is that there are risk factors that can predict of PI in acute pancreatitis. Last but not least, we asked the question, does PERT decrease the PI symptoms in patients with acute pancreatitis? Here we use the PICO framework, and we hypothesize that PERT can decrease the PI manifestation in patients with acute pancreatitis. We conducted a systematic search within state databases, and after the whole selection process, including the citation chasing, 58 articles were eligible for systematic review and meta-analysis. We finished the analysis the PI rate, PERT use date, and the risk factors of PI in acute pancreatitis, and we are still waiting for further data regarding the PERT effect from the authors. Let me show you some of my results. On the first plot, you can see the proportion of PI in acute pancreatitis. This is important because, as I mentioned, untreated PI can cause several intestinal symptoms and leads to malabsorption and malnutrition. Here, the overall measurement, the proportion is 0.20, which means that 20% of AP patients develop PI during the follow-up. Our next outcome is the odds of PI development, and we are investigating patients after severe acute pancreatitis compared to patients with mild acute pancreatitis, and the odds ratio is 1.99, which means that the odds of PI development is 2 times higher among patients with severe acute pancreatitis. Here you can see results for the same outcome. However, here we are comparing patients, AP patients with necrosis to patients without necrosis. And the I-square is 79%, and the confidence interval is also very high. So, which means that there is high heterogeneity here. Therefore, based on this forest plot, we cannot conclude whether necrosis influenced the odds of PI development or not. Here we are comparing patients with infected necrosis to patients with sterile necrosis, and the odds ratio is 2.13, which means that the odds of PI development is 2 times higher among patients with infected necrosis. This result is almost statistically significant and absolutely clinically relevant, and further studies with a higher amount of article can lead to a mathematically significant result. Here we are comparing patients who underwent necrosectomy to patients without necrosectomy, and we can see that the odds of PI development is 3 times higher among patients with necrosectomy. Here we are investigating patients after surgery compared to patients who were treated by endoscopy. And the overall effect shows that surgery is associated with a higher risk of PI development. However, we can notice a high heterogeneity here. Therefore, based on this forest plot, I rather would say that PI can develop even after surgery and endoscopy. The strengths of our study includes that we have robust scientific methodology and clinically relevant analysis. However, the meta-analysis was limited by the fact that the outcomes definitions varied among the studies, and they have checked the outcomes at different time points. As a conclusion, our results shows that the proportion of PI is 20% in acute pancreatitis, and the odds of PI development is higher among patients with infected necrosis and after necrosectomy. Therefore, AP patients should be followed up and screened for PI after an episode of AP, moreover in case of infected necrosis, and after necrosectomy, more frequent control visits needed. And further research needed to investigate the role of infection in PI development. Regarding my first project progress, I can say that we are almost ready with the data extraction, and I am currently working on the risk of bias assessment. And as an overview, my first project started in September, and my goal is to submit it in May 2024. And I would like to close my presentation with the words of Rosalind Franklin: "Science and everyday life cannot and should not be separated." Thank you for your kind attention.
I don't like your rule to take answers, because I didn't get to ask any answers, so I'll ask one now, or two. One is, we know from other literature that 20% of acute pancreatitis patients develop chronic pancreatitis. Is this the same 20% or not?
I think it's a different person, because we also collected data regarding how many patients will develop CP after EP.
And not all of them have got CP.
Yes.
And the other question is, there's quite a significant variation in the proportion of PAI in the post-AP population. Does that depend on the time you follow up the patients?
Yes, I think so. There were many reasons behind it, but maybe the main reason is that the studies, the duration of follow-up time were different in the studies, and the etiology and the severity also influence the proportion.
Okay, thank you.
Okay, thank you, Orsolya, for your presentation. So, if I understand it correctly, as a clinician who works with these patients, what do you think is the ideal timing of starting PERT, and what is the ideal time of ending it? So, is there a time frame? Do you see anything about that? Thank you.
Thank you for your question. As guidelines for EP-related PI still not exist, therefore I cannot answer, so I don't know the exact answer. but further research absolutely needed to investigate it.
Thank you for your presentation. It was really good. I would like to ask how did they diagnose PEI in the included studies?
Thank you for your question. It was also a huge limitation of our studies because the definition were varied among the studies. However, the most commonly used diagnostic tests were the fecal ALS one.
If I may, one question. Your first forest plot has like 98% of heterogeneity reported and a huge range of the proportions in each study. So are you planning or did you already do some subgroup analysis that could explain this heterogeneity?
Yes, we are already thinking about that. Maybe based on the follow-up time, we will perform a subgroup analysis.